So at what point does it become serious along the way? Like at what point? You have to decide when it becomes serious. Hey guys, I'm going to start off today. Well, welcome to another Warrior1Spine episode. We're blessed to have Dr. Pascal here and his expertise and his knowledge and his wisdom. And that's what I want to start off with. With Yuri, myself, and Pascal, after you're doing the reconstruction, for 5 years, 10 years, 15 years, 20 years, 25 years, 30 plus years, what tends to happen is that the reconstruction process in terms of the protocol is actually just comes like second nature. But what all of us have to do, even if we've been out for 20, 25, 30 years, is it's really important for us to come back and stay really close to the why we do what we do. And that's why I just want to chat about a little bit, just as an intro, is just staying close to the why, because the bigger the why, the bigger the practice. The bigger the why behind what you do, the bigger the miracles you're going to see and the transformation you're going to see in people's lives. And so we're going to talk about posture today. And obviously, one of the one-liners that we've heard, I'm not even sure who the first person that actually brought up, but posture in itself is, we call it the window to the spine. So bad posture, it has to bring you to bad spine, right? And because if it doesn't, then everybody right now apparently does posture work, whether it's the physios, the different types of therapists, the kins, the guy that's your trainer at the gym is going to improve your posture. So what we have to do is recognize that where our sweet spot, where our expertise is actually correcting posture by correcting the spine. And so it's not like an aesthetics thing, although that might be the entry, as I'll actually go through a couple of just examples. That might be the entry point, like my kids got really bad posture, but along the way, the conversation has to change. And the conversation will change effortlessly if you continue to just be specific on why you're there. And so, a good question to ask ourselves is, when we're looking through the progression of posture through the spinal damage and decay, at what point in this process does it become serious, right? Because I hear, and I'm sure Dr. Pascal, and I know for sure Yuri, is like, when younger chiropractors come in, is like, well, my patients just don't get it. Actually, it's not usually the patients that's not getting it. It's that the fact that you're trying to get the patient to get it. People will start believing, but they're there to actually hear what you believe. And you have to stay focused on what you believe. You deliver your belief, and then whatever happens after that, right? And so, but the question to ask yourself, at what point does this become serious? And for me and for Yuri, a phase 1 is serious. A phase 2 is serious. A phase 2 is not more serious than a phase 1, because we know the phase 1 eventually just gets to phase 2. A phase 3 is serious, and a phase 4 is serious. And if you think that just phase 4s are serious, well, how do you get to a phase 4? Well, you got to go through 3. And how do you get to 3? You got to go through 2. And how do you get to 2? Well, you got to go through phase 1. And phase 1 might be like the starting point of, a person starting to come off of what healthy, of what a normal, spine is in sagittal. And so that's a good question to ask yourself. At what point do you believe it's serious? Because that's going to change the interaction, the relationship, the communication that you have at every moment. Like, Yuri talks about the moments of truth. At every single moment of truth, it's going to change that interaction, not from what we're doing, but more so to why we're doing it. I always come back to bringing the patient back to the why. And for me to be able to do that, for Yuri to be able to do that, for Pascal to be able to do that, it's that we actually have to bring up the why. We have to let our why surface up to that interaction. And so at what point of this progression does it become serious? Or another question, or another good question or visual is just look at this, okay? So at what point does it become serious for you? So at what point does it become serious along the way? Like at what point? You have to decide when it becomes serious, because if you want your patients to take it seriously, we as doctors have to take it seriously. And we have to define and continue to define what we do, but more importantly, why we do it. And this is a video that was done by CBP, which is an amazing video. When you actually Google this video, this time-lapse cervical degeneration video, it shows up all over the place, and I'm sure that not everybody has permission to use it. But one of the comments that actually I'd seen, or one of the titles to this, it was actually underneath this video. It wasn't from DEED or CBP or anybody associated with CBP. It was just somebody else's kind of clinic byline kind of thing. And it was basically said that this is the normal progression of aging of the spine. Well, you know what? It's not. This is not a normal progression of aging in the spine. This is a normal progression of subluxation in the spine. Yes, everything's degenerating within the spine, but it's supposed to be degenerating equally. And you know what? Obviously, this is not equally distributed degeneration. Therefore, it's subluxation. And that's just from a mechanical perspective. We're getting a visual of the mechanics, but can we assume that, remember there's a spinal cord in here, and can we assume that there might be a little stenosis happening with that spinal cord, which ultimately means that brain is getting disconnected, choked off to body, right? But it all depends on what you believe. But the point is at what point during this process as degeneration does this become serious for you, doctor? And it's really, really important to continue to ask yourself that. And a little bit while ago, actually a couple of years ago, I believe that we had Dr. Dan talking about how posture predicts longevity, morbidity, and mortality. And we had that at leadership. And I actually even chunked, I don't know, a 7-hour presentation to, three studies in 5 minutes. And why I did that is because we know that the attention span for the average chiropractor is very, very limited. So, just with these studies here, these are 3 studies, right? So hyperkyphotic posture predicts mortality in older community dwelling men and women. So hyperkyphosis posture predicts mortality. Persons with hyperkyphotic posture had a 44% increased rate of mortality. 44% increased rate of mortality. And this ain't no chiropractic journal. This is a journal of the American Geriatric Society. And this is not cutting edge stuff. This is, already a almost 18-year-old study, okay? Way back when, okay? 44% increase in rate of mortality correlated to hyperkyphotic posture. Another good one here is the spinal posture in the sagittal plane is associated with future dependence in activities of daily living. So even if you have a hard time communicating mortality rates associated to degeneration and hyperkyphosis, well, let's just like, if you want to stay independent, your future dependence actually correlates directly to your spinal posture in the sagittal plane. Accumulated evidence shows how important spinal posture is for the aged populations in maintaining independence in everyday life. All right, so that's huge to get, okay? So it's important, okay, for the aged population. But at what age does it become important? right? And how much change can you bring to a phase 3 and phase 4? And yes, we bring change. And yes, we see people go from wheelchairs, walkers, the walkers, the canes, and canes to no canes. And those are awesome stories. But our greatest impact are the ones that are in phase 1s and phase 2, because they've lost up to a certain point and they've experienced a certain amount of loss, but they're gonna lose so much more life and quality of life in the future if something doesn't change. And that's where you come in. And, I wanted to just go over a few examples here. Now, get this, all these examples, okay, all these kids, I'm using young people, okay, so they're not kids, but I've seen them all since grade school, okay? So this is Jessica. She's 19 years old. She's at Carleton University. And I've seen Jessica since she was 9 years old. So, it's been like 12 years, 12, 13 years. And she first came in off of, hey, do you think you can check our kids? Yeah, your kids for free at no expense. This is part of what we value. This is part of what we do. This is part of who we are. So I checked Jessica, and she has no curve whatsoever. Actually, she's starting to reverse as a 9-year-old. And one of their symptoms that she was expressing was bedwetting. Well, within 12 months, we got the curve. And yes, I did take a picture, a radiograph of a 9-year-old. Why? Because she had subluxation and I want to correct it. So I take an X-ray. And yes, I did take a post X-ray at 6 months and a post X-ray at 12 months. And she had this beautiful curve back, and it just so happens she stopped bedwetting between 9 and 10 years old. And I've seen her regularly at once a week for the past, since then. At 19 years of age, she had some sort of trauma, and I forget what it was, I think it was a car accident, but we took an X-ray, and she went from her normal, okay, or her healthy, reconstructed spine to this. This is August 2019. And so wow, right from the trauma, we're starting to lose again. So what are we going to do? Well, if it was important then, well, it's important now. So Jessica, we're off, and that's going to happen. If you walk through life with these patients through a lifetime, you're going to see times where there's trauma and we take a post X-ray and we've lost and we got to get back. Why? If it was important before, it's important now. It's going to be important in the future. So what we do, Jessica, is, we got to up it from once a week. We got to up it to twice a week, and we got to get back to some pretty intense tractioning. This is January 2021, okay? And by the way, she had no symptoms here, 0 symptoms, okay? No symptoms whatsoever. We took a post X-ray because she had bad trauma, okay? And this is her, whatever, a year and a bit later, okay? So yeah, that's awesome. And we want to continue to progress, right? Because we can improve we know we can continue to improve, but 0 symptoms, okay? But what's the why? This is Karen. Karen came in, I saw her as a tween initially, and she was a little rambunctious during her teenage years, and she didn't want to start care. So I think I restarted care with her 3 different times during her teenage years, and she would never follow through with care. Her mom was a current patient, but if a teenager doesn't want to come, the teenager is not going to come. Well, now Karen's a 21-year-old nurse. She's got massive neck and upper back pain. She's got massive digestive issues. She comes in and we take this X-ray. I actually show her an X-ray of her as a tween, and I say, look, you see, that's the issue. She's seen all sorts of specialists, going through all sorts of tests, can't find anything. And I said, yeah, well, we need to get your curve back. My recommendation is the same recommendation I gave you, 5 years ago, 8 years ago, 9 years ago. And this time she followed through, and this is a little over a year, August 2020, okay? So awesome, no more pain. She absolutely loves coming in. So during her teenage years, she hated coming in, big eye roll, sign of contempt. And she didn't want to listen to mom, didn't want to listen to me. But now I see her as a 22-year-old nurse. She's moving into full correction. She actually referred in the past, during COVID, she's referred in 3 other nurses that are undergoing care simply because I stay close to the why. Stay close to the why behind the what, guys. This is Hiba. Hiba, 15 years old, August 2020, came in because, oh, you check kids for no fee. Okay, well, I want to get all my kids checked. Hiba didn't even know why she was in. She had 0 symptoms, but this is serious. Why? Because it's subluxated. Okay. Why? Because we know where this is going. The normal progression, the normal degeneration of subluxation, this is getting worse. Okay. So she starts care. And this is Hiba at 6-month X-ray, twice a week for 26 weeks. Awesome. Okay. 0 symptoms still, right? This is Zach. Zach came in, 17-year-old student. He's a water polo dude. He's a climber. So and he's a lifeguard. So he's fit. He's tall. He's lean. He's fit. You'd look at him. You'd say he was healthy, but he's got this posture. Mom hates his posture. He's all stooped over. Well, I had to sit down with Zach and say, like, yeah, you got bad posture, but you got a bad posture because you got a bad spine, and we need to fix this. This is serious, okay? And he followed through twice a week for 26 weeks. I just took this one in August. This is him 6 months later. Awesome. But if it wasn't serious, and if I didn't believe it was serious, he wouldn't believe it was serious. And there's no way we'd actually get this change. And we just changed the rest of his life, okay, with this. But it all depends on what you believe. This is Tony. Tony came in. Actually, Tony, I just took this X-ray yesterday. It was my last X-ray that I took yesterday afternoon. It was like a half hour. I think it was like 5:30, and I wanted to post this up. So Tony's 34-year-old computer engineer, started February 2021. And you look at his curve, well, the lack thereof, we're starting to have a start of reversal here. We start to see the lipping, the degeneration, the spinal phyte formation here and here. And it just so happens, right below the reversal, this is where the load moment is happening. And this is a phase 2. How long has this been here? Well, if he's 34 years and it takes 20 years to be able to see, osteo visibly with my naked eye, well, I can assume it's been there for about, 20 years at least, okay, give or take, right? Well, that would put him as a 14-year-old, just like all the other cases. Well, how important would it have been if Tony would have walked in as a 14-year-old? Well, if a 14-year-old Tony walked in, you could have actually corrected it, and he wouldn't actually have this degeneration going on. But he's now a 34-year-old. What was important then, it's important now. And I just post X-ray yesterday, 3 times a week for 13 weeks, twice a week for 13 weeks. I post X-ray. You see this. This is why I wanted to share. Okay, yeah, I post X-ray, and the next thing we do is, okay, we're gonna sit down. We're gonna go over your X-ray. It's a report time with me. And he says, Doc, I trust you. I feel amazing. How about you just tell me how it's going? And I go, no. And he looks at me and goes, no. I said, exactly, no. He goes, what do you mean, no? I said, no, we're going to sit down together. We're going over this. Why? Because it's important. Because you were a phase 2 reversal osteoarthritis as a 34-year-old, been there since most likely your early teens. And this is just getting worse. So you know what? If it was important then, it's important now. And we're going to sit down. And all of a sudden he goes, okay, let's sit down. So we're going to sit down, and you got to stay close to your why in your moments of truth. This is exactly why at 30 plus years, Yuri's in the game. This is why Pascal takes time out of his busy schedule to actually, lead us in the research and his expertise and the spinal reconstruction process. And this is why we get up in the morning. It's part of our calling. Stay close to the why. Yuri, Pascal, over to you, sirs.
There we go. Sorry, I couldn't get unmuted. Thank you. And let me go screen share here. Yeah, Doc got me fired up. I love it. And to answer your question, it's serious in a phase 1. If you could ask me, where do I want to see my patients? Give me phase 1s all day long, right? I mean, 1, this is where it starts. 2, they're the easiest ones to get the correction and then keep them there. right? Like who wouldn't want to see a problem that's in its infancy that it's much easier to correct and then say, hey, let's keep you here for life. This is much easier than waiting till you're a train wreck and then we're doing intensive care for, 2-3 years trying to get you back to the best reasonable spine possible and living with the damages. So phase one all day long. And it ties in great to the presentation because today we're going to talk about the effects of COVID on posture, right? And can everybody see my screen here? Can you guys see my screen? Yep, good. Sorry, went to the front. So the effects of COVID on posture, we're going to be talking about actually getting young, flexible patients that have mild to little or no degenerative changes, right? In essence, phase one. Dr. Deed used to always talk about posture, just hearing you talk about posture, Dr. Ed, he used to always say that, the posture being the window to the spine. But when he would describe someone's posture and how they're, shifting out of balance in that forward sagittal balance, like you were talking about the Rancho Bernardo studies and those kyphosis papers where you see people starting to round forward, when it's visible in the posture, he would call it a subluxation. Their posture is subluxated because the posture is so closely tied into the spine that if the posture is off, that patient is subluxated, no questions asked. And so, tied in aptly to what we're going to talk about today, the effects of COVID and how it's starting to affect posture in our patients, right? And if you've been in practice for any amount of time, maybe some of you are new and you've started in the pandemic, but I'll assume that a bunch of you have been practicing pre-COVID. And so you've seen the changes probably in your existing patients. Dr. Ed, you mentioned the trauma. Well, if it's not a macro trauma, but maybe the micro trauma of now, instead of, getting a proper ergonomic workstation at work, you've got people doing this stuff at home, right? Sitting in front of a laptop on a couch. Countless patients of mine have told me they're doing this now. They sit on a couch, head goes forward, they have the shoulders are rounded, and they're spending 8 hours a day like this, right? And there's all these other lockdowns and restrictions. And so they're not going to the gym as much. They're not exercising. They're not moving. And you have people that are spending every single day, hours a day in these bad postures. And I think this picture, shows it the best. You see this exaggerated kyphosis developing in this young man, and his head is driving forward. I mean, yes, this is probably a picture that was done on purpose. It's exaggerated, but it teaches us what is happening with the spine when someone starts to spend numerous hours in this position. The good news for you as a chiropractor, as a doctor, if you catch it early enough, right? Phase one, early enough, it is extremely easy to correct and get back to normal or an unsubluxated state. So if you're starting to see this in your patients, what can you do about it? Well, we can use something called the posture regainer. So we're going to talk about using the posture regainer today to undo the effects that COVID is having on the posture of our patients, specifically those that are at home, quarantined, and spending time in very poor ergonomic positions. So here's a classic example of it. Okay, so you have a young man, and I hope that you guys are looking at posture in your patients. If you're saying that the posture is the window to the spine, and that posture can teach you or show you if a patient is subluxated, you'd better be looking at their posture. It takes, a minute to review their posture in an exam. So with young men, I always have them go shirt off. With women, if possible, I have them come with a tank top or a sports bra so we can look at their posture. And you can see here, this young man is very evident, right? You can see the increase in the rounding in this young man's rib cage. You can see he's getting a more pronounced kyphosis. The head is being driven forward, right? If I'm using something like posture screen, I have landmarks. I can use the external auditory meatus, and if not, you can just do this by hand. You put a dot at the AC joint. You're supposed to have a dot at the trochanter, and this one should actually be a little bit further forward. And then the most important one, and then is your reference point, which is the lateral malleolus. So we would want ideally a good posture in sagittal profile. We'd want all of those dots lined up. Well, in this case, you can see this young man's trochanter. So his pelvis is forward. His AC joint is behind the pelvis. So his rib cage is backwards, and his head is forward of his AC joint. So the head is forward, right? You get that triple combination. If I take an X-ray, if you're taking those lateral full spines or thoracic X-rays, you'll notice that large swooping increase in his thoracic spine. So this young man has an increased thoracic kyphosis, and we can clearly see that the head is going forward. Okay, so what do we do in a situation like this? We're going to use this tool right here called the posture regainer. Okay. So here are our indicators for using a posture regainer. And I love the name, right? It's very aptly named. You got a posture that's crappy, it's breaking down. You're going to use a tool that's going to regain the posture. So here's the block itself, okay? And then here is a picture of me. Hopefully you can see the picture of me laying over top of this thing. It is a very aggressive or assertive roll. So we have indications for which to use this. In other words, here's the recipe that I'm going to give you. This is not set in stone. You're always going to be the doctor. I'm giving you a recipe. In other words, I'm giving you a guideline. And what you could do is you can modify this as needed and use your clinical expertise to decide that, oh yeah, maybe this patient doesn't fit this perfect recipe, but I think this is a great tool to use in this case. Okay, so you can see where I'm laying here on my back. It's doing the exact opposite of what I showed you in that young man. Okay, so if I was to put a dot at my trochanter, I put a dot at my AC joint here, you could see that that posture regainer is driving my posture forward. It's flattening. It's actually almost got my thoracic spine into a flattened state or a lordosis, and it's allowing a ton of cervical curvature to happen, right? And then there's that forehead strap. If you could see it, you could put that forehead strap if you want, that's optional, and it drives the head further back, really increasing the cervical lordosis. It's a wonderful tool to use when we choose the appropriate patient for it. So what would some of those indicators be? Well, a postural kyphosis. So in a minute here, we're going to switch screens and I'm going to teach you guys the difference between a structural kyphosis or a true thoracic hyperkyphosis and a postural kyphosis, one that's being generated by early stage breakdown in the posture, such as a phase 1 subluxation. So they have a very large posterior translation of the posture. So like I showed you on this young man, right? The posture has shifted backwards, right? If you want to look, you could almost like break up the spine into sections, right? You could take the thoracic spine, you could kind of highlight the lumbar spine, and you could kind of highlight the cervical spine, right? And so if I'm looking at the chunk that represents my rib cage, it sits posterior to my lumbar spine, just like this, or posterior to the center of my pelvis if you want to use the pelvis as a chunk. Okay, so we want to see a posterior shift in their posture. The thoracic kyphosis is generally going to be less than 60 degrees because when the hyperkyphosis or when the posture is the driver of the increased kyphosis, it's going to stay at approximately 60 degrees or less. And a pizza angle. If you haven't watched the previous webinars, this might be a little bit confusing to you, so try and go back and watch them. For those of you who have been following throughout these and studying and understanding this, the pizza angle is a measurement that we take on the cervical film that gives us an indicator as to whether or not the patient is truly hyperkyphotic from a structural standpoint of view. So we want a pizza that's under 75. So we'll review that cervical measurement in a few slides, okay? And then we want a younger, more flexible patient, right? Because once they start to break down and they've been there for a long time and you're getting into phase 2 degenerative changes, there's no way a phase 2 or very rarely will a phase 2 patient be able to do this on this roll. It's just too much for them. Okay, so you want that younger, more flexible patient. And over 5'5". I mean, I'm 5'7", and you can see it's really working me hard. My head was barely touching the table here. It pushes me forward quite a bit. So if your patient is shorter, I mean, if they're very flexible, no problem, they could probably use it. But generally, it's rare that I'll give it to a patient that is less than 5 foot 5 inches. And then, of course, mild degenerative changes, aka phase 1 or less, phase 2 really, but really phase 1 would be ideal for using this roll. All right, so if you've used thoracic Dennerolls in the past and you haven't used the posture regainer, you might be asking yourself, well, what's the difference and why would I use a posture regainer? Well, I put them side by side here in side profile. Look at the difference in height. Okay, so the posture regainer is a monster, right? It's like 6 inches in height. This is about 4 inches in height. So there's a big height difference in how far forward it pushes that rib cage. When you look at it in front profile, you can see how wide the posture regainer is. Its job is to not only push on the spine, but push on the shoulder blades, push on the entire thorax and drive it forward. The thoracic Denneroll is designed to fit specifically between the shoulder blades to flatten a very specific area of a hyperkyphosis, okay? So you want to use the posture regainer in a case of postural kyphosis, and you'd want to use something like the thoracic Denneroll when the patient has a true structural hyperkyphosis or deformity, okay? So I gave you guys the indicators for the postural one, right? A large posterior shift, a thoracic kyphosis of approximately 60 degrees or less, and their pizza under 75. Well, when you have the opposite of that, right? When you have very little to no posterior shift, and you have a thoracic kyphosis that's above 60 degrees, And if you're measuring your cervical films and you have a pizza above 75, ding, 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 you're going to be using a thoracic Denneroll. Try not to give these patients one of these guys because they typically won't tolerate it. They're not going to be flexible enough to lay over top of this big baby. Okay, so that's the main thing I wanted to drive home there. And if you want to look at it in side profile, to make it a little bit clearer, here's a case of true and here's a case of postural kyphosis. So you can see in a true kyphosis, we use this guy. In a postural kyphosis case, we use this guy. So if I don't say anything, we just stop and take a moment and we look at these two films. Don't look at any of the measurements. Just look at the red and green lines. And quick plug for Postural. If you're not using Postural, it's a great software. It makes your life easy because it puts the ideal line on the film for you. You just, put all the dots on the bones and it shows you where the patient should be and where they are. So on the left, these red and green lines intersect almost the whole way. In other words, this person's thoracic spine has not shifted behind the reference line at all. There is no posterior translation or very, very little in this case. I come up to my thoracic measurement, it's 66 degrees. So I've got someone that has not shifted backwards and they've got a large rounding in the thoracic spine. That is a case where I don't want to push the spine forward. I want to allow this to flatten and allow the shoulders to come backwards. I would use this guy, okay? Now here is a classic textbook case of using a posture regainer. So you have the green reference line here, and you have this young lady who's the red line. And you can see, she has a substantial posterior shift. It's 3 inches or 75 millimeters backwards that she has shifted. Her thoracic spine is measuring 59.5, so right at that 60-degree mark. This is a classic textbook postural case. And what I'll explain to you in a moment here is that as someone shifts backwards, the spine has to round in the thoracic spine or in the shoulders to maintain balance. Because if it didn't, right, what's going to do is going to round in the shoulders and drive the head forward. If it did not do that, the person's head would be like way back here. I'm drawing a head way behind the pelvis. They would be completely off balance. They would fall. It doesn't work. So the brain is a beautiful thing. It was designed to help you stay alive, right? And so if I start to have this backward shift, naturally my body's going to round my shoulders and try and drive my head forward to try and keep my head balanced over top of my pelvis. So there's a natural compensation that happens. That's what's called a postural kyphosis. If I took an X-ray seconds later on this young lady and I taught her how to properly rehab her posture and I drove her forward, I almost pushed my hand on her back and said, stand as tall as you can, straighten up, try and hold that. And I retook my X-ray seconds later, this measurement would be 44 bang on because the kyphosis is entirely generated by her bad posture. So if that's unclear, when we open it up for questions after, we can rediscuss that. Here's another way to discriminate between a true and a postural kyphosis. So you got, again, a perfect case here. Dot on the greater trochanter, the AC joint. You can clearly see this young man's rib cage has shifted behind his pelvis. He's got a posterior shift. It's pretty evident. You look at the rounding. He's got some hyperkyphosis, right? The head drives forward. We've got all 3 of those indicators. If you want to know if it's a true or postural, you can have them hold their hands together and bend forward. Okay. So these are obviously all 3 different patients, but it's just to give you guys perfect examples. So here's a case of a true hyperkyphosis. When they bend forward, if I still see this really large pronounced kyphosis or hyperkyphosis when they bend forward, and obviously he's very unflexible, this is a true hyperkyphosis case. This is a great case to put on a thoracic Denneroll. Okay. Here's the opposite. Here's a younger, taller, more flexible patient, likely phase 1, who bends forward and almost a perfect arc. You did see just a little bit there. I should take my ink off here again. You see a little bit of a hump here, but very small. For the majority, his thoracic spine rounds forward beautifully and consistently. So this is a case where the kyphosis that I saw in his posture was almost entirely due to his slouchy posterior shift. Okay, so if you're taking thoracic films or you're new to thoracic films and you say, Doc, I want to take some of these thoracic films, but how do I measure it? You've mentioned the normal curve, right? You've mentioned a thoracic kyphosis. How do you measure it? Well, it's just the same as we measure our cervical films. So you've got normal values here. I've got them written out, normal values. I've given you two options. You can measure from T1 to T12 or T3 through T10. Why? Well, because sometimes we don't get T1 on our films. We cut it off by accident. Sometimes you have patients who are very thick in the shoulders there, and your X-ray beam doesn't penetrate and you can't see T1 properly. So you have two options, but always use T1 through T12 when you can. So I take my lateral thoracic film, I take my top bone and my bottom bone. Okay. All I need to do is draw two lines and measure the angle between. It's George's line or a posterior tangent. I put a dot, right, at the posterior aspect, superior and inferior aspect of the bone. I connect them. That yellow line goes all the way through. I do the same thing from T12. Dot, dot. I connect them and draw my line all the way up, and I measure my intersecting angle. Okay. That measurement to be normal should be 44 degrees. In this case, you can see this gentleman's rib cage measured 30.2. So if you measure a thoracic spine and it measures less than 44, especially if it's substantial, like if it's 41, 42, and they have the other indicators in their posture, you could probably still use a posture regainer. But if you're getting something down into the 30s and the 20s, they're not posture regainer cases. So if you're having values that are sub 44, especially if they're substantially less, they are not, again, I quote, they are not posture regainer cases. So we have our normal values, whether it's T3, which is 37, or if we go from T1, which is 44, what happens, as I mentioned earlier, as the posterior translation happens in that thorax, the ribcage rounds, and you're going to start to get an increase in that thoracic kyphosis up to a certain extent, right? It can only increase the thoracic kyphosis so much. It kind of tops out at about 60 degrees. So anything above that means, if you're getting a value above 60 degrees, it means that there's also a little bit of structural component to that kyphosis. Okay. But if you're really talking about a posture regainer case, they're going to hover right about 60 degrees in their kyphosis. Okay. If you're using T3 through T10, approximately 50. Now, if you're just doing cervical films, you could all use those posture indicators I showed you in posture, and you're going to measure this off the cervical film. So I'm going to state this very slowly, and I'm going to repeat it twice. When I'm measuring my cervical films, the indicators for using a posture regainer are identical to those for a cervical Denneroll. Okay. So last year, I taught you guys about differentiating on cervical films between using a cervical Denneroll and a thoracic Denneroll for a true hyperkyphosis case. So a postural kyphosis is going to have the same cervical indicators as a cervical Denneroll. So that's why it's important for you as a doctor to do a proper exam, to look at the patient, to study their whole posture and not just their cervical films. Because if you're giving them a cervical Denneroll, well, you're missing out on the whole postural subluxation below the neck. Okay, so what are those indicators? Well, number one, it's a very large head translation. Okay, so these are the indicators. If my values are above these, I'm thinking my patient is truly hyperkyphotic and they need the yellow thoracic Denneroll. Okay, so anterior head translation, how far forward that head shifts, C2 over C7. In this case here, this gentleman is 50 mils. Okay, once it's close to 50 or above 50, generally the reason it's so far forward is because it's being generated by a very hyperkyphotic spine. Slope of C7 and T1 to vertical. T1, remember from last year, I put a dot at the back of T1. I draw a vertical line up. Okay, so a dot at the back of T1. I draw a vertical line up. I take that posterior George's line like I do to measure all my bones, right? And I'm measuring the angle between vertical and T1. If that value is above 30 degrees, okay, so if this angle is above 30 degrees, the patient is truly hyperkyphotic. Structural deformity, yellow Denneroll. If it's less than 30, then you can consider giving the patient a posture regainer. So above 30, yellow thoracic, less than 30, posture regainer. Okay. And you can correlate it with your pizza angle, right? So if I've got a T1 that's well above 30, like this case, you see like 45 degrees, and the pizza angle, so a quick refresher on that measurement, I find my sternum, my manubrium sternum, you put a dot at the top of it, and then I use that same line behind T1. Okay, that was my George's line behind T1. I'm going to connect the top, so posterior superior aspect of T1, down to my manubrium sternum, and I measure the angle. Okay, so this guy's got like a 90-degree pizza angle, right? Well above my 75-degree cutoff. So if I've got a T1 that's like above 30 and a pizza above 90 and a very large anterior head translation, it's not a posture regainer case, okay? It is a thoracic Denneroll case. So I'll give you an example here in a second. Here we go. So now I do my posture exam. Here's that same young patient, okay? I see the indicators. I take my cervical film. Here's a case that my indicators work for a posture regainer. So I put a line up from T1, right? Sorry, that's supposed to be vertical. I measure from the back of T1, I measure to vertical. This guy's 25 degrees, okay? So 25 is less than my threshold of 30. I have my first indicator. My second indicator, right, was my pizza angle. Well, it's already measured for me, right? So manubrium sternum, I connect the line from the top, right? His pizza angle was measuring 69 degrees, less than my 75-degree cutoff. His forward head posture is 27 mils, less than my 50-millimeter cutoff. I've got all three of my cervical spine indicators for a posture regainer. He's got all the postural indicators for a posture regainer. But let's say I wasn't looking at posture. If all you were doing is just quickly snapping films, I take this cervical film and I'm going to give the patient a cervical Denneroll. Is that an error in this case? The answer is no, because this patient meets all of the indicators to use a cervical Denneroll. So a cervical Denneroll is appropriate for this patient and will give this patient good cervical results. But will a cervical Denneroll address the rest of the posture and the problems that we see from AC joint down? The answer is no. So what's the better choice in a case like this is to give a patient a posture regainer. So hopefully if you are taking the thoracic films, then you'll notice that, yeah, this patient has a 65-degree kyphosis. So just a little bit above our cutoff, right? So it's close. And now listen, it's 65. If it was 75, I'd be thinking there's more structural deformity. 65 could just be because I measured a little too quick and my lines are off. He's pretty close to that 60-degree limit. So I'm going to give this patient a posture regainer. Okay. And here are his neck changes after 3 months. So at 3 months, we pop an Xray to see how he's doing and check up on him. And boom, he goes from a 15-degree curve to a 37-degree curve while using the posture regainer. Okay. Phenomenal changes. And had those changes, would they have happened if I had only used a cervical Denneroll? It's possible, but I wouldn't have seen the changes that I saw in his thoracic spine and in his posture overall. Okay. So again, the indicators for the posture regainer are identical to those of the cervical Denneroll. You make your choice based on either the lateral thoracic film or the other postural indicators when you're doing your posture exam. So I hope that's clear. All right. To muddy the waters and to hopefully not confuse you, but to show you that you need to be the doctor, or for those that are doing more advanced work and you want a bigger challenge, I'm going to give you a case that doesn't fit the recipe that I gave you to show you that you can use this outside of my recipe when you choose to do it for a patient, when you think it's appropriate based on your clinical expertise. Because remember, you are the professional, right? You truly are the experts in putting people's posture and their spine back to normal. So we've got a young male. He's 13 years old, okay? And he's 5'8". So check. He's younger, right? He's above 5'8". So he meets two of our criteria. Now I say younger, it's really semi-flexible, right? This guy's obviously going to be in a phase 1. I say semi-flexible and not very flexible because he is spending so much time gaming. So this is not COVID, but we're seeing the same thing in COVID. he is spending so much time gaming, and it's even worse now because of COVID, because he's not doing anything outside of sitting at his computer, that his hamstrings are tightened up. Like, look, he can't even straighten his knees, right? He's got such tight hamstrings and a tight low back that when he stands, his knees are bent. So his thoracic curve is a whopping 84 degrees at his age. That is a problem. Remember, I told you normal was 44. I told you postural increases were up to approximately 60 or just slightly over 60. So this means that this young man has, a good 20 degrees of true thoracic deformity, right? So that was my question, was, is it a true hyperkyphosis or a postural hyperkyphosis? And what do you do in a situation like this when, his thoracic curve is so high that it goes above our cutoff for using a posture regainer? Well, the answer here is that it's both. It's both a postural kyphosis and a hyperkyphosis, a true structural deformity. He has elements of both. In other words, his thoracic spine is 84 degrees because he shifted so far back. There is some increase from posture and compensation, and he has true structural deformity. So now, being the doctor, I have to choose, what am I going to do for this patient? Well, he's so young, he's so flexible, that as much as I'm concerned about the rounding in his shoulders, I'm more concerned about, the red line being so far behind the green line and the collapse that I'm seeing. So yes, the rounding in the shoulders is a problem, but the rounding in the shoulders drives the head forward. It's going to cause this lumbar spine to collapse. So I'm going to choose to put this young man on a posture regainer because I think that's going to have the most drastic effect at first. I'll check back and take my X-ray at 3 months and look to see how I'm doing, and then decide, okay, if I've corrected the postural component, maybe then I'll move in to the structural component and use a thoracic Denneroll, right? So you can approach it like a two-tiered system. So I chose to give this young man a posture regainer. I had him do this exercise against the wall. And I should mention that every single patient that I give a posture regainer to, I teach them how to do this on the wall. If you imagined I was laying down, it's the same thing, right? I'm just actively having somebody do this against gravity. They put the roll between their shoulders, drive their pelvis back to the wall, right? It drives the chest forward. I have them open their palms. We spend so much time kind of down pronated that I have people open up their hands and bring their arms back to really stretch out the chest and pecs, and then look up slightly and drive the head backwards, right? It's a form of exercise I call the Titanic. I have them hold it for 10 seconds and repeat a minimum of 20 times. Okay, so he was doing that and then laying on it every single day for 15 minutes. Here is what his spine looks like after 3 months. So after 32 visits in 3 months, I do my follow-up X-ray, I check, and boom, wow, stunning correction. Okay, I wasn't expecting it to be this good. I wanted a good correction. He's young, right? As we mentioned earlier, just like the intro Dr. Ed was talking about, when is it serious? He's 13 years old. That alone to me is serious, that I'm seeing subluxated posture, that I'm seeing this kind of deformity at his age. And so giving him the posture regainer took out not only the postural deformity, it corrected the majority of his structural deformity as well. He goes from an 84-degree thoracic curve to a 48-degree curve in 3 months. The sad part is he fell off care. Mom didn't keep him coming. He came back in a year and a half later. He hadn't completely regressed. I should have thrown in the X-ray. He went back up to 60, low 60 degrees in his thoracic spine. Mom said, of course, he's gaming. He's not doing anything. He didn't follow through on his chiropractic care. He regressed, went back to being subluxated, right? Mom said, yeah, we're going to start care. They came in for 2 visits. Same thing. Mom disappeared. There's some family issues there that we unfortunately couldn't, like Dr. Ed said, you tell them why, you give them your best why, you tell them how we're going to do it. And unfortunately, I couldn't keep them on track because it was really sad to see that this young man's posture was breaking down again. But anyways, the possibility is there to drastically change lives when you know how to intervene, when you have the clinical confidence to do it, and you do it as early as possible. So I hope that helped. We're going to open it up for questions here in a second. So just one more time, what you're looking for in a posture regainer patient: a very large posterior translation of their posture, thoracic kyphosis of less than 60 degrees or approximately 60, anterior head translation is less than 50, and pizza under 75. You want a younger, more flexible / phase 1 patient. typically over 5'5", with mild to no degenerative changes. So thank you again for being on here. As always, there's a coupon code if you guys want to go on our site and purchase Dennerolls. That'll give you 10% off all of our products for the next 2 weeks. Here are my email addresses. So again, as we open it up for questions, remember guys, I want questions regarding the posture regainer, regarding the effects of COVID on posture. If you have specific clinical case questions about a patient that you have that is different than a posture regainer case, email me or contact me personally just so we can stick to the content here. And then again, some videos on my YouTube channel for other Denneroll products of how to use them and how to help patients. So yeah, we can open up for questions and let's see if there's anything that we need some clarification on.
Yeah, I've got a question right off the bat there. On that
Yes.
last patient, Pascal, would you
Yes.
also prescribe core exercises?
Absolutely. And I did, yes. All my patients, sorry, I should say, sorry, what kind of core do I do?
Yeah, well, something like that. Like he's obviously got an anterior translation of the pelvis too.
Yeah. So I mean, you could get into all kinds of core corrective exercises and trying to teach them specific to patients. And what I found is it is almost more time consuming, more complicated. And so we've just got 6 basic core exercises. And so every time a patient comes in, the very next day, once we review their x-rays, we send them a video of the 6 basic core exercises that we want them to do. And it's got a portion of the doctor's report in there. So it's like an educational piece built back into the exercises. So we have all of our patients do the cat-cow. Okay. Why? Because you get spinal extension and spinal flexion. So building mobility into the spine, right? So they're on all fours. They get into extension, flexion, just creating motion in their spine. We have them do either the dead bug or the bird dog, trying to do some sort of cross crawl where, the brain is engaged, trying to move opposing limbs while stabilizing. We have them do planks because planks is probably, if they do it right, if you think about posture, side profile in a plank, ears in line with the shoulder, pelvis, ankles. It's a beautiful postural exercise. So plank and side plank. And then we have them do generally, not all cases, but the majority, a hip bridge because of just people not exercising and having very weak glutes. And then, so the bridge and then the McGill curl up are the 2 wild cards that we give selectively to patients. If someone has a very flattened forward head, sometimes I won't give them the hip bridge because in that position, it drives, the head into sort of a posterior translation with flexion. It's not a great exercise for the neck. So the hip bridge and McGill curl up are the 2 that I will prescribe. But always cat cow, bird dog or dead bug, plank and side plank. Those are like the classic core that if they do those and they did nothing else, their posture would improve to some extent.
Perfect. Yeah, thanks.
And I think we're going to cover my favorite exercises on the next webinar. So we'll go through them. I'll go through them in detail and how we do them and how I give them to patients and such. If you went back, if you thought about that shot that I showed you where the patient was laying on the posture regainer, like myself, 5'7", it's taking up, 2/3 to 3/4, if not more, of my thoracic spine. Most of the time, the posture regainer, you just put it in the thoracic spine and don't worry about where the apex lines up. You don't want the apex or the edge, because I mean, really the apex of the posture regainer is the edge where it kind of drops off. If you have the apex up at like T1, you're not really going to get too much flattening of the spine. It'll be great for the cervical curve, but you're not going to get the flattening of the thoracic spine that you want. And if you put it too low, I mean, it's almost going to be sitting inside their lumbar spine. So you don't really have to worry too much with the posture regainer. If you're selecting those cases appropriately, the whole posture has shifted backwards. Slam it right behind the shoulder blades, which is, T8, the middle of the thoracic spine. And you'll see as they lay on it, their bum should be able to touch and their head should be just about touching the ground. It's perfect. That's kind of how I look at it, is if the glutes are touching and the head is just about touching the ground, it's perfect. I don't think about it more than that.
Thanks.
No problem. All right, gentlemen. Well, if nobody else is piping up, till next time, thank you again for doing
Thanks a lot, Ace.
My pleasure. Have a great weekend, guys. I know you guys are doing some coaching at Hunt Club, so hopefully it's a rocking weekend, and we'll see you guys in a couple of months. Awesome. Okay, guys.
Thanks,
Take care.
Pascal.